morning, everyone. My name is Beth Ancatel. I'm a registered nurse and the clinical liaison for Brookhaven Hospice. I'm here today to discuss hospice services and care with you. So I'd look to identify hospice, touch upon the eligibility of hospice, and talk and discuss the services and benefits through hospice. But before I do that, I do want to take a brief moment and talk about the modern history of hospice, because hospice is truly an ancient philosophy. As long as people have been here, we have taken care of our loved ones through their entire life process, including up until the end of life care. And that's what hospice is. But to bring it forward to the modern hospice movement, I'd like to just touch upon a few points. In 1963, Dame Cicely Saunders introduced the specialized care for dying at Yale University. In 1967, she opened the first hospice house in the United Kingdom. In 1972, the U.S. Senate had its first national hearing on the subject of death with dignity. In 1978, the National Hospice Organization was formed and established. At the same time frame, the U.S. Department of Health, Education, and Welfare reported that hospice was a viable concept. In 1982, Congress included a Medicare hospice benefit for the first time. And here we are 40 years later. Hospice model of care is still going strong, supporting the seriously ill and their loved ones. In fact, hospice has probably been a little bit more in the news lately, because just under a month ago, former President Jimmy Carter released a statement in which he confirmed his decision to spend the remaining time at home with family under hospice care, foregoing any further clinical curative treatments and interventions. To be clear, to define hospice, and again, to be clear, hospice is end-of-life care for when treatment and curative measures are no longer pursued. Hospice care focuses on comfort and quality of life for a person with a serious illness. So really there's a shift in care for those who go from no longer looking for active curative treatments and focusing that treatment and care on comfort and the quality of life. Hospice eligibility is determined when a doctor believes an individual has 6 months or less to live if the illness runs its natural course. And this is the tricky part, because no one has a crystal ball. What we do know, though, is that hospice does not hasten death, and hospice benefits are underutilized in this country. Hospice is a Medicare benefit. All care, medications, and equipments associated with a hospice diagnosis are provided to the individual and their families at no additional cost. So truly, it is an extra layer of support. So what is hospice services and benefits? What can you expect? Hospice is a team approach. We have nurses, personal care assistants, social workers, chaplains, the medical director, and our trained volunteers. The nurse case manager will be the lead person. They come to the individual for their initial and second day visit. They coordinate a plan of care Again, focusing on comfort and quality measures of life for that individual and their caregivers. So in partnership with the individual and their caregivers, they create a plan of care that typically includes daily visits. Hello.
My clock wasn't set right.
Oh, no problem. Welcome.
In my car.
Welcome, welcome. What I was just talking about is what hospice benefits and services include, and then I can spend more time with you and kind of backtrack if you'd like. So the plan of care that the nurse creates with partnership with the individual and their caregivers not only focuses on the medical needs, but also the social, emotional, and spiritual needs of that individual. So each plan of care is unique to that individual and their caregivers. However, a typical plan of care would include nurse visits once or twice a week for 1 hour. Personal care assistants would also come in about once or twice a week for about an hour. And then the social worker, the chaplain, they come in typically about twice a month. Again, this all depends on the needs of the individual. Our volunteers really provide another additional layer of support, and truthfully, they make quite a meaningful impact. Now, hospice care is an approach to care treatment. So that means the care comes to the individual wherever home is. That could be in a family home or in a skilled facility. Hospice care is available to individuals so long as that illness requirement, eligibility requirement is met, and care is provided as long as needed. At any point, an individual wants to change that focus of treatment and care from comfort measures, quality of life, managing symptoms of an illness, and switch it back to a more curative, intervention, they can. They would just switch off the hospice benefit and resume their medical care. So those kind of talk about the services of the provider. The additional support would be medications. All medications associated with the hospice diagnosis would fall under the hospice benefit and be provided at no cost through the Medicare program. Equipment. What equipment is necessary to help promote quality of life? That includes hospital beds, the tables that ride over the bed, oxygen, incontinence products, commodes, things of that nature that will help support the family and the patient. And finally, the last component of a hospice service would be bereavement support. Each team has a bereavement coordinator that will continue to support family and loved ones at the patient's passing. A program lasts typically about 13 months, again, depending on needs, and we want to be there and support families through those milestones that occur within the following year. Before I answer any questions you may have, I do want to also mention there's some information in the back. We do always look for volunteers. If you feel that that might be something you'd like to do, there's information and we would be happy to talk to you about that. So, any questions? Yes?
Yes, would you like to describe the difference between palliative care and the hospice program?
Yes, excellent question. So hospice and palliative run very similar in the sense that they are looking to manage symptoms of an illness, how to promote quality of life. However, palliative treatment runs along at the same time as curative treatments. For example, if someone is undergoing chemotherapy in treatment of a cancer, they may also have palliative to help manage the symptoms of pain, nausea, at the same time as seeking chemotherapy. Hospice would provide the same support for treatments of nausea, pain, but it's when an individual no longer is looking for that curative chemotherapy treatment. So they're very similar.
Well, what happens if somebody has like Alzheimer's and they're in the late stage?
Yes.
Because I had an aunt who was put on hospice. She was put on hospice 3 different times because that's supposed to be, you have less than 6 months to live.
Yes.
I don't know if that's changed. But a relative said, well, why don't you just give her palliative care? But I don't.
So, yep, that's a great question. And dementia is one of those diagnoses in Alzheimer's because there are stages of the disease, but we don't have that crystal ball to know how quickly a patient will pass. So hospice, you are correct. Hospice benefit by definition is when a doctor believes that a patient has 6 months or less to live if that disease runs its natural course. There are times when people, we quote unquote graduate from hospice because those declines that the disease progress was going kind of stop. And they make rebounds. They may gain weight. They've increased their movement, and they no longer meet that eligibility. And then down the road, they may come back on it. So hospice will be provided as long as people meet that medical eligibility criteria of 6 months or less. And as I was saying earlier, we don't have a crystal ball. We do not know. Hospice coming in earlier in that disease progress helps kind of minimize some of those declines.
She was 13 years.
Oh my goodness, the longest I've heard in our agency was 5 years.
13 years in a setting, never mind, she had it like 3 years prior to that.
Okay.
And in the end, really, she was on no medication for anything, which, she didn't have diabetes, because everything was neutral.
Right.
She couldn't even walk.
Yeah.
So that was like a case for the books. But some of the relatives said, well, why don't you just give her palliative care? And I really didn't understand the difference between the two.
Yeah, so that palliative treatment is is very similar. So they're looking at the symptoms, they're looking to manage any discomfort, promote quality of life, but palliative medicine works at the same time as like interventions. Mm-hmm. So, for example, like Jimmy Carter, and many people that we know, they come in and out of the hospital towards the end of their life, and they just no longer want to do that. They want to manage those symptoms at their home, whether it be in a family home or in a skilled facility. They just say, let's focus on comfort, quality of life, and forgo any medical interventions. Mm-hmm. So, yep, it goes as long as the patient needs it. So that would be the key. If you no longer want curative medical interventions, palliative medicine stops and hospice picks up.
Mm-hmm. Okay.
And again, the other benefit of the hospice model of care is that it supports the family, and it would provide bereavement services at the passing so that family have someone checking in and making sure we're...
Is the bereavement services fairly new to hospice? Because when she died, we weren't offered anything.
I'll be honest, I'm not sure. I believe it has been part of the model for some time now.
Which, are you out of a particular hospice?
I'm with Brookhaven Hospice out of Westboro.
Okay.
Yeah. The other thing that you brought up, I think, is really important to talk to about, because hospice sometimes, because people come late in the game or in that model of care, their impression is that you go on pain medicine and you're in bed and we slowly off to sleep you go. That is not how model of care works. It really is individualized. So if a patient like your aunt has no pain medications are given. Mm-hmm. If there is discomfort, pain medicine is given. If patients do not need oxygen, then we don't supply oxygen. We actually try to encourage the good days. especially when people are still independent but have that terminal illness and they have chosen to focus on their comfort and quality of life. If they're having a good day and they want to go paint their nails, then we support that. Please head out, go visit family, do what you would like to do. So it's really trying to individualize that care plan, focus on what would make that individual happy. Come on.
Now, at one point, her bones were so brittle she broke her hip. But because she was never gonna walk again anyhow, they wanted to do surgery on her and she wasn't even verbal. And I refused. I said, what are my options? Which was good because if they forgot to give her pain medication, you know, she couldn't verbalize. So I opted to just do pain patch.
So I'm so glad you advocated for her. And that's again, like, it's a nuance. It's a little bit of a shift in the way you think. So medical doctors, a lot of times, and it's appropriate to offer the options, but that's a curative intervention. And we have to weigh the pros and cons of that. And like you say, if someone is not in distress, they have that fracture, that broken hip, but maybe they're not a good candidate for surgery, or it just...
She was wincing, so they knew something was wrong, but the doctor was very upset that I chose not to have her go into surgery.
I'm sorry. And I
But I'm
felt
not
that
sorry.
way. Well, I'm appreciative that you were there to advocate for her, because surgery we're lucky to have such good hospitals in the area and great medical care in this state. But there comes a time when individuals and families are going to choose comfort and quality of life. Surgery is very tough on an individual and can decrease the quality of life after that procedure. So it's important to let people know through advanced directives, through conversations, to say, I really want to support comfort. So we don't want to leave a patient wincing. And there's pain patches, there's other medications that can be given. And that's what hospice is there to focus on. And that's kind of the partnership that hospice tries to create and work with families, because you know your loved ones better than anyone else. So our nurses would be looking towards the caregivers, the loved ones, to say, boy, I'm noticing she's wincing. Is that normal? What can we do? Let's try these. Is it working? And I should actually come back to one very important matter that I forgot to mention, which is, yes, we have the visits, and that's wonderful, but what about the other times of days? What happens in the middle of the night? And this is very important. Hospice agencies, we have a 1-800 number. So 24 hours a day, 7 days a week, you call that 1-800 number, you're going to speak to a nurse. And we're going to provide support, guidance, answer any questions, provide support if there's any concerns. If that conversation warrants a visit from a nurse, whether it be in the middle of the night or during the weekend hours, we have runner nurses, and they come to the individual. Of course, we try to support and provide the care direction through the phone, but again, we have runner nurses, we call them, and their only job is to come and make visits.
So is this covered under Medicare Part A or B or what?
I don't know the breakdowns, but what I do know is, and I had looking this up, so in 1982, the first Medicare benefit included hospice. Hospice became part of the Medicare benefit. So hospice benefit through Medicare, and I've seen Part A, Part B. We always verify prior to services, and but Medicare provides hospice services, so that's the people that provide the care, the medications that are needed to help support that hospice diagnosis, and all equipment at no cost to the individual or their family members. And one thing I'll say is, I think is a big help, especially in our elderly population, is all incontinence products. I know those can be quite costly at times. So the hospice Medicare benefit. And that's been going on for over 40 years. And I've been a nurse for 10 years now, but I've been in the hospice, which is really why I started nursing to begin with. And it brings me great comfort and pride that our government has recognized that this is a benefit that should be offered to all citizens of this country, and extra support to family and to the loved ones for the terminally ill and seriously ill patients.
Yes.
Any other questions? These have been spot on. I can't thank you enough for your time. I'm going to be here if you have any questions and you want to talk privately, we can do that. Again, thank you so very much for coming today. I appreciate it.